Thank you very much, Jagged, and thank you also, Dr. Sharma and Dr. Keeney, for the gracious invitation, the opportunity to speak to you today a little bit. And I'm going to touch on some clinical areas, but also touch on some areas that interdigitate with what Dr. Rich spoke to you about as well. I have no disclosures. So briefly, what I'd like to talk to you about is a vision that was actually held about 16 years ago, trying to look at predictions for what would happen in medicine, some shifts in healthcare, some of which Dr. Rich has touched upon, technological advances that may influence what we're going to be doing in 50 years or less, some things about bringing the future of medicine into our practices today. And then I also want to talk about some practical points about the immediate impact of what's going on both technologically and socioeconomically that impacts the way that we see patients. As background, I'll tell you, I'm a clinical cardiologist in Southwest Florida. Our system is a 4-hospital system in a catchment area of about 750,000 people. And one of the problems that Dr. Rich touched on was the divergent populations. And I actually have a map of our catchment area that is color-coded based on our heart failure readmission rates. And it's exactly the same type of problem that you experience here. So this is a nationwide issue that we have to watch. So this is from a paper written in 2000 by the futurist Joe Flower, along with past presidents Lynn Dreyfus and Fred Beauvais, along with Bill Weintraub, that tried to predict where we might be 50 years from then. And they got a number, they commented at the time that we would be at the point in 50 years where one went in for an appointment, simply got a drop of blood that made the diagnosis and helped move forward, that people would be doing better because of exercise, plenty of sleep, moderate habits. I'm not certain we've achieved that at this point. And that we'd have increased organ transplants and nano labs. So that was their prediction looking long term. And some of the things that they got right 16 years ago had to do with the fact that they knew that we would have demographic shifts and increasing cost pressures that are occurring, as you saw, at a geometric rate, a flood of new technology, which is very exciting but has to be tempered by the cost. And then we would see also radical changes in technique and understanding of the pathophysiology, particularly of cardiovascular disease, at the same time that we saw changes in the healthcare system. This is a slide that I actually borrowed and then modified from Jeff Ginsburg, who's a well-known genomics expert at Duke. And if one thinks about the geometric progression of medicine, on the left, there's data that goes back to about 5,000 BC, looking at prehistoric surgical techniques that were being practiced on an intuitive method. The first physician recorded in hieroglyphics in Egypt was about 2,500, Hesi-Ra. In 1000 BC, the Persians began making treatises on medicine, and probably the first medical textbook was between the 3rd and 5th century BC in China, the so-called Yellow Emperor's inner cart. Now, if this whole thousands of years of medicine then progressed on with some variation with regard to intuitive medicine until one reaches about the 20th century, if you follow this logic. And around the mid-20th century, actually in 1967, Alvin Feinstein published Clinical Judgment, starting to look at utilizing data in an organized fashion. But the term evidence-based medicine that we throw around so rapidly was actually first quoted in JAMA in 1990 by David Eddy. So this is a relatively recent development when one thinks of the centuries and eons since the development of medicine. And now we're rapidly moving to the next phase, where we're looking at individual algorithm-based medicine, some of which is genomics, but some of which is using things like computing power to look at even something as simple as family history, to begin to individualize and move toward precision medicine. So we're in a geometric progression. We're moving very rapidly, and for many in the audience, this transformation from that middle panel to the right panel is going to happen during your practice lifetime. Right now, what we're seeing, the shifts that are occurring from a practical and clinical standpoint, are we're seeing an increased use of non-hospital or non-office settings to try and reduce costs. You saw some of that in Dr. Rich's slides, moving from the hospital outpatient, but even moving from the office to outside the office, utilizing other settings, pharmacies, big box stores, telemedicine to try and reduce costs. We're also seeing a broader use of electronic records, greater access on the patient part, particularly based on the internet, to a lot of healthcare information, some of which is correct and some of which is not, but a lot of information flowing. And then changes in delivery system, particularly with the passage of MACRA. You saw some of the changes that are coming down the pike, and some of what Dr. Rich showed you is a result of MACRA. Now, this is all part of this shift from a volume-driven to a value-driven healthcare system. Reduction in cost, which is an economic reality and pressure, and it really doesn't matter whether you and I like it or not. The cost curve is unsustainable, and it is absolutely imperative that the cost be dropped or the system will collapse under its own weight. But we also now have the ability to measure value or measure quality in ways that we didn't have 2 decades ago. And that drives the quality part of the value equation, which I would submit to you is an imperative that's more moral and ethical on our part, but also is going to be measured by people who are watching us on a regular basis. So let's talk just for a moment about the background of MACRA and what it actually did. This came through in 2015, and it repealed the sustainable growth rate, the SGR. Quickly, for those of you in the audience, the SGR had promised a 21% reduction in reimbursement for Medicare services that had been staved off for many years by a lot of efforts on the part of a number of organizations, including ACC, had held off, but we had a cliff that was looming that was going to drop reimbursement by 21%. Had that occurred, large institutions like this one and even small practices would have been devastated, because if you've run the business of medicine before, you know that that sort of drop in 1 year is simply not something you can absorb. But as a payback, when Congress did that, they had to figure out a way to pay it, and they were looking at the slide that I just showed you about a shift from volume to value, and so they established frameworks that did this. Now, very, very importantly on this slide, I want to point out that little blue box in the bottom left-hand corner. And this is really important because, especially in an election year, there's a temptation to believe that this may go away. But in fact, MACRA was passed overwhelmingly, even in the House of Representatives, which is really divided, was passed by an overwhelming majority, and then was passed on to the Senate that had no problem, and then signed by the President. So the point is that this legislation is not going to be overturned. Implementation may modify, but this is not going away. So the timeline is very rapid. We're waiting right now for the final proposed regulations to be finalized this fall. We still don't have it out yet. It's any moment now. But look at the bottom at January 2017. That's the beginning of the measurement period. So if you think that all this development or modification of medicine is in the far future, remember that measurement of your performance, which will affect your payment beginning in 2019, begins just a couple of months from now. Now, you'll hear a lot of terms. I won't spend a lot of time on this, but the so-called MIPS, or Merit-Based Incentive Payment Program, I would point out, look at the boxes. Quality, meaningful use will begin to go away, but resource use, that's a code word for cost, and you heard Dr. Rich comment on that, and then clinical practice improvement. So you see the terms that are creeping in here that begin to tell us the way we are going to be judged, not on the volume of what we've done, but on some other things. Now we're moving from MIPS, and a smaller group of us will be involved in alternate payment models, and these will progress on. Some of us will be in those immediately, although it'll be a smaller percentage of, for example, cardiovascular specialists in the United States. But look at the bottom left-hand corner there. By 2023, they're expecting that over 75% of total Medicare revenue is going to be based on alternate payment models. That's not very far away, is it? And so we're looking at a fundamental paradigm shift in the way that medicine is managed in the United States. Most of us who do this and have looked at it very carefully believe that this paradigm shift will equal or surpass the Medicare Acts back in the mid-1960s. So this is something that, while I like to listen to talks on heart failure, atrial fibrillation, and imaging, we cannot ignore. You've got to be aware of this. You can't put your head in the sand. This is happening rapidly. Now, on top of this, on top of macro, separate things, CMS notified us on July 25th and then released the paper in early August about bundle payments. Now, some payment areas have been working on bundle payments for a while, but this is a CMS initiative, and it shifts quantity to quality with incentives for better care at lower costs, and involves, among other things, heart attack and bypass surgery. Now, it also, as Dr. Rich alluded to, makes us responsible not just for the costs in the hospital, but for 90 days out. And so we're going to have to work together to figure out how this works. I think it's actually an interesting and exciting opportunity, but it's a different challenge than what we faced before, and it shapes the way we're going to practice both in and out of the hospital. What's happening clinically, and what are the curves that affect us? Well, if one looks at what happened, over the last couple of decades with regard to, in cardiovascular arena, with regard to catheterizations in the dark blue, PCI in the light blue, and then cardiac surgery in the other two colors, you see that particularly when PCI began to really take hold, especially as evolved stent technology took place in the mid-1990s, and we saw that abrupt increase, you saw a flattening of the curve with regard to heart surgery. Now, in a way, that was a hint even back then, because what they were finding was a way to, hopefully, in a less expensive way that involved less morbidity, so I'm talking about cost and quality, hopefully, we saw a shift from one technology to the other. But the other thing I'm going to point out to you is at the very end of the curves, if you look at the cardiac catheterization curve, the dark blue, and even the PCI, you notice that by 2005, these curves are starting to level out or begin to decrease. And if you extrapolate the curves out, particularly if you look at the data after 2007, the publication of the COURAGE trial, you see that the numbers have started to go down. And a lot of this has to do with science, but a lot of it has to do with cost pressures. And this is a reality of the area that we practice. Here's the data that I just alluded to. Look what happens to U.S. PCI volumes in 2007, around the time of the publication in New England Journal of the COURAGE trial, comparing a medical therapy with PCI for stable patients. So in extraordinarily gifted areas where we have advanced ability at extremely high quality, such as this institution, we're still seeing high volumes because they're delivering superior care. But if we look at the nation as a whole, we're seeing a change and a shift in the way that we're delivering medicine. Now, it's not limited to PCI, certainly. If you look at nuclear imaging, look at the curve and look at what happened in the around 2005, 2006. You see the abrupt drop-off. Now, I will tell you, as an ACC person and one of the people that was involved in the early efforts to start appropriate use, it just so happens that that curve changes about the time that appropriate use criteria were introduced in the United States. Now, in fairness, and Minnow, my colleague, who is an expert in nuclear imaging, she and I were talking about it this morning. There are a number of things that happened around the time that also influenced this, but the point is that cost pressures along with data have shifted the curve. So what about the demographics? We talk a lot about the demographics of our patient population, but here's an area that isn't discussed quite as much. This is a slide from our people at ACC that talks a little bit about, in fact, appropriately, if you look at the gray bar, the graying of the cardiovascular specialists. And if you look from 2002 to 2015, you see that gray bar which is 61 and over, an age where 25 years ago there were not as many practicing cardiologists. But look at the increase, now 30%. If you look at it a little bit differently and you look at a breakdown, you'll see that if you look in the area of general cardiology, this is based on 2014 MedAxiom data, that we've got 37% of practicing general cardiologists that are basically 60 or over. Now, the reason this is important is not because you're going to have to bring me a walker to help me make rounds. The reason this is important is because you have to worry that if two things happen simultaneously, namely a drop in reimbursement and increased complexity of health records like Epic, and it happens at the same time that the stock market goes up, you're going to see a lot of your 62-year-old colleagues decide that they're going to go play golf. And if that happens and you've got 37% of the general cardiologists that are in that age group, we could have a real problem on our hands. I don't know about you, but I'm swamped when I'm on hospital service. And if we had a drop in my community of 37% within a 5-year period, it would be catastrophic. And this is what we're looking at. These are the real demographics of what's happening in the United States. So with that piece of backdrop, what about the technology? Well, we've got some extraordinarily interesting and exciting technological opportunities. Some of them I've just listed here. I won't read them off. And what about on the horizon? We've got some really exciting things that also will influence the way that we practice in the office and in the hospital. Genetics are just beginning to take hold. I alluded to personalized medicine before. Right now, you can already send in a sample to several companies around the country and begin to get ideas about your genetics with specific disease entities. But we believe that's going to expand fairly rapidly to widespread access. And as we develop better databases, we'll have better data management and understanding of what genetic predisposition involves other cardiovascular diseases beyond those that we look at right now. That'll move us toward personalized medicine, not only with diagnostics, but with regard to treatment as well, and synthesis of gene-specific pharmacy. 3D printing, starting to be used already, particularly in some areas. The cardiovascular surgeons are using this in training with regard to congenital heart disease, translating imaging over to 3D models that help them look before they go into the operating room. This is already present currently. However, integration of 3D printing along with live cell technology or biocompatible polymers has a really interesting niche with regard to development of artificial organs or vascular structures, and really could revolutionize the way we treat patients. And this technology is moving at a geometric pace as well. BioMIMS is already here. Nano Robotics is right around the corner. So we've already got, in its very simplest form, smart watches and fitness trackers and Fitbits and the like. We also now have FDA approved implantable pulmonary artery pressure monitors that can help us potentially with management of heart failure. But very rapidly, we're talking about nanorobotics that could be inserted in the bloodstream with sensors that could detect disease before there are clinical signs and even process and begin to develop drug dispensers. So this is all on the drawing board, and remember that when we first saw Star Trek, those of you old enough, and they had this little thing that they opened and could communicate, we thought that that was wild, and now those are old flip phones. So this technology is moving rapidly. In the area of artificial intelligence and cognitive computing, we've got a number of companies that have invested huge amounts. The Microsoft team, led by Qi Lu and Harry Shum and Rajesh Jha, have got an artificial intelligence team. Google has the DeepMind and has been working very hard, particularly in the translation area. IBM has Watson. You're all familiar with that if you watch Jeopardy. General Electric has the Predict system. We've got voice recognition on our cell phones. We've got self-driving cars that may replace replace the way we transport in the very near future. And if you think about this, this has the possibility for rapid diagnosis. And in fact, there are a couple of places that, particularly in the oncology area, are already utilizing artificial intelligence programs for diagnosis and treatment of oncologic disease, but disease management, remote clinics, particularly in rural areas, and one could even imagine patient care robots that might not look like this fellow, but perhaps could have characteristics that are helpful. 3D virtual reality and augmented reality, interestingly enough, being used currently in two spheres. One is the gaming area, but the other is actually, for those of you who don't know, is in the construction area. My son has been using virtual reality for years now in the construction industry, constructing large projects. We already have a couple of institutions that are beginning to use this with regard to procedural learning, and you can imagine that this could be used for remote medicine as well. All of this presents with it some ethical challenges, some regulations with regarding the sale of organs that might potentially be manufactured at a fairly high clip, the use and access of genetic and personal health data, the hacking of systems. We're all concerned about this, especially in this current day and age, and the ability to maintain privacy as this increased database is out there. The cost is a real concern because I showed you we're trying to get a handle on this, and none of this is cheap, and who's going to pay for it? And particularly related to that, is there going to be equal access for those who are less privileged and don't have the ability to pay for this sort of thing? So what about right now in our offices? How do we bring some of this technology and some of these shifts, sometimes in a low-tech way, right into our office? Well, the first I would submit to you, and this relates to the graying, if you will, of the population, but it also relates to expertise, and that is beginning to expand the use of team-based care with efficient use of advanced care providers for management, particularly as there might be less of us walking around, but also increased interaction with clinical pharmacists, physical therapists, dietitians, and others that have expertise in areas that's far beyond what I do. I know that in our system, we utilize multidisciplinary teams in a number of areas, but particularly in heart failure, where the team compromises a number of people that have expertise in areas well beyond the heart failure physician because they have specific interests in areas that contribute. And genetic counselors have become crucial as well. Remote telemetry is already here. We've got, you saw the app that Dr. Rich showed you with home weights. We've got implantable monitors. And I don't know how many of you utilize the technology. I certainly do in clinical medicine. Sometimes if you have the person that you think is having atrial fibrillation on only an occasional basis, the use of mobile phone applications is extraordinarily helpful to try and make diagnoses, and it's very cost effective. We're moving rapidly to population management. You're already seeing the development of risk pools. You may have more of them here in New York than we have in Southwest Florida, although we're increasingly becoming responsible for the care of risk pools, and this is something that comes right into our practice now. And then we're already utilizing, particularly in cardiovascular disease, selective genetic testing right now for some specific entities, but that will expand pretty rapidly very, very soon. So practically, what does this mean for us, and where do I see this in my practice and perhaps yours in the very, very near future? And by that I mean in the next year or two, and even now. The first is that in the hospital, we're already seeing an increased case complexity. The rationale for that is that the simple cases are all treated as outpatients as well. When I first started practice, we actually brought diagnostic heart catheterizations into the hospital for a 2-night stay, a pre-op and a post-op. It seems, ancient now. None of those patients are hospitalized anymore. They're all done as outpatients. Secondly, there's a shift toward less invasive evaluations that may be more cost-effective, and you'll hear some of that this morning by experts in this field that are looking at extraordinarily innovative ways to image without having to be invasive. Outcomes metrics, Dr. Rich alluded to this as well. We've had this on a hospital basis to some degree for a little bit of time. And many of us in the room are already getting some of our outcomes data from things like the National Cardiovascular Data Registry. But even those of you who aren't in the cath lab or involved in cath PCI will begin increasingly to be brought by your chief or your senior partner or whomever a list of what your outcome metrics are that will measure your performance. And this is going to be crucial, because if you look at that cost and effectiveness curve, and you think about bundled care, it's not a fairly quick leap to realize that your outcomes are going to dictate not only your paycheck, but whether or not you have a job next year. Because if you have a bundled care program from MI and your outcomes are poor, at some point your partners are going to say, maybe you need to think about doing something else for a living. So this is real, and it's coming very rapidly. There's going to be increased scrutiny for appropriateness and cost, an emphasis on team care that I touched on. Out of the hospital, we'll have increased case complexity as well, because a lot of these people are going to be treated by our colleagues in family medicine, and as some of the numbers shrink, will be faced with taking care of the most complex case. The remote monitoring I've alluded to, telemedicine. We have efforts in Congress right now to begin to get reimbursement for telemedicine, because one of the hindrances right now is when we do this right now, most of the time it's for free. With bundled care, that changes. Increased use of time value units rather than RVUs that levels the playing field for providers, and we could talk more about that at another time if you like. An increased supervisory role, that is, what we're going to see increasingly is instead of the cardiologist making rounds on her patients on a given morning, she's likely to have 3, 4, 5 people who are working with her, and she may be acting in a supervisory and consulting role. And an emphasis with the patient on shared decision making that brings them into the loop with regard to what we're doing. So our group of Flower, Weintraub, Beauvais, and Dreyfus said back in 2000, imagination is rapid, but progress is often both uncertain and slow because of constraints of cost, regulation, and time. But we can now foresee a future in which medical science might actually defeat cardiovascular disease the way it has some other diseases. So is this good or bad? I guess it depends upon your personality. I have to tell you, from my personality, I actually think this is good for 2 reasons. The first is the ability to access this sort of rapidly expanding technology and leverage this to being able to care for patients at the bedside is extraordinarily exciting, and it's probably more exciting in cardiovascular disease than in any other field that we have. It's an unbelievable opportunity in time. And the opportunity to be able to actually measure what we do and compete with ourselves to try and provide more cost-effective care is good as well. So when we think about all the changes we've made, when we changed from groin approach to radial artery approach, it could be a little bit frustrating and a little bit of a learning curve at first. And then once you do it, you say, gosh, why didn't we do this all the time? And this is the same thing with some of the transition in healthcare. The journey can be a little bit rough, and it's going to be rough over the next couple of years. Don't fool yourself, because a lot of the things with macro are not going to happen instantly, and as they evolve, it's going to be very difficult. There will be mistakes along the way, and there'll be some wailing and gnashing of teeth. On the other hand, I think that the type of audience that we have here that's on the cutting edge, that are accustomed to being highly educated and highly motivated, are exactly the type of people that are going to thrive in that system and do very well to the betterment of patients. With that, thank you very much.